Hello, esteemed master and practical class members. One of the most important roles of ultrasound is to serve as a guided injection tool. Diagnosis matters, of course, but guidance is where ultrasound truly changes outcomes. In the early days of ultrasound-guided injection, the goal was simple: be more accurate than blind injection. That was the standard. But as experience has grown across the field, that standard is no longer enough. If we stay at this basic level, we cannot move forward. We have to go beyond the show, beyond the visible performance of the procedure. Giving patients reassurance and gaining a placebo advantage is not enough. It will not lift the position of the ultrasound interventionist above the competition. It will not advance the field. This lecture is about the foundation. And building that foundation solidly is what makes rapid progress possible later. Here is something worth remembering. The human brain uses an enormous amount of energy, more than 30% of the body's total. So the brain naturally tries to conserve. It builds habits, and those habits become the default pathway. This is why so many ultrasound practitioners form the wrong habits from the very beginning, and never correct them. I have seen many skilled clinicians held back, not by lack of knowledge, but by habits they cannot undo. So you can think of this lecture as a guide to forming the right habits from the start. The early sections, aseptic technique, ergonomics, are things everyone already knows. And yet, most do not actually follow them. People give reasons: my setup, my staff, my equipment, my circumstances. These are real, but they are also excuses. Once a habit is formed, it is very hard to change. If you are just starting out, take this seriously from day one. If you have already been practicing, use this as a chance to review and reset your system. That is exactly why this lecture was made. Let's begin. Before we move on, here is how this lecture is organized. There are 3 parts. Part 1, Setup. Everything you do before the needle touches the skin. How you prepare the room, the patient, and yourself. Part 2, Technique. How you handle the needle, choose the probe, and control the injection. Part 3, Interpretation. How you read the ultrasound image during the injection, and what it is telling you in real time. All 3 parts matter equally. All 3 must work together. One weak link breaks the result. First, sterility, the most important step. The absolute foundation. Before anything else, one principle. Sterility is not optional. Yet many doctors skip this step, or cut corners on critical parts of it. Precision without sterility is meaningless. We are placing a needle into a controlled anatomical space. If contamination occurs, even a perfect injection becomes a complication. So always follow proper sterile technique: skin preparation, sterile gel, a properly applied probe cover, and a sterile drape covering the procedural field. I will show you a short video of how our staff prepare the field, and how I prepare myself.
I've been up since 3, scrolling back where we used to be. Half truths in this late night chat, both of us knowing what a lie that. Funny how we talk like we're fine, but your name still lives in my rhyme. Take me back to the start, before the quiet and the scar.
One practical point worth noting. Beyond the basic preparation, there are several smaller steps that matter just as much. In very superficial areas, the wrist, for example, the skin is thin and the target sits close to the surface. In these cases, it is often safer to puncture the skin first, and then place the probe. If you place the probe first and the entry point sits too close to the probe edge, you risk puncturing the probe cover. And that means contamination. Another point: when performing multiple punctures, change the needle. A single contaminated puncture can transfer pathogens from one area to another. Changing the needle also reduces injection soreness. Repeated punctures dull the needle tip, damage the tissue along the needle path, and lead to more pain, both during the procedure and afterward. Small details. Big consequences. Think one step ahead. Always. Second. Patient position, lying down, without exception. Every procedure must be done with the patient lying down. This is not about comfort. It is about safety and control. A supine or recumbent position lowers the risk of vasovagal reactions. It stabilizes the patient, which stabilizes your hands. And it lets you keep proper ergonomics throughout the procedure. If the patient is sitting or standing, you lose stability. Your needle control becomes inconsistent, and your margin for error shrinks. The rule is simple. The patient lies down. Always. Third. Ergonomics, the single most important factor for a sustainable practice and a healthy body. Now we come to what I consider the most critical element of the entire setup. Ergonomics. If ergonomics is wrong, everything becomes harder, and your body pays the price. Not because of poor knowledge, but because of poor mechanics. Most failed injections are not caused by weak anatomy knowledge. They are caused by poor positioning of the operator. Your eye, your hand, the needle, the target, and the screen must all sit on the same visual and physical axis. Your monitor should be directly in front of you, ideally just beyond the patient, so your gaze moves in a straight line from your hands to the image. You must be able to glance between the probe and the monitor without tilting your head or rotating your neck. If you have to turn your head, your setup is already wrong. Hand height, probe angle, and visual axis must be aligned. When they are not, you lose the needle. The tracking breaks down, and the procedure breaks down with it. If your shoulder is tense, if your wrist is awkward, if your neck is rotated, your setup is wrong. Fix the ergonomics before you proceed. Never compromise this. Now I will give you 50 seconds to rethink your own position. Watch the video, and reflect on your setup as you watch. Good ergonomics is not just for today's procedure. It is for the next 20 years of your career. Fourth. In plane technique, why full visualization is non-negotiable. Let's define what in plane really means. In plane means the entire needle, the shaft and the tip, is visible in the ultrasound image at all times. Not just the tip. Not just a bright reflection. The entire needle. I will show you a video demonstrating in plane technique across several procedures: cervical facet intra-articular injection, cervical periradicular injection, interscalene injection, and the lateral approach to the tibiotalar joint and the anterior talofibular ligament. In pain management, this is not a preference. It is a requirement. You will see many out-of-plane techniques in regional anesthesia. That is a different field, with different tolerances. In pain practice, do not use them. Pain interventions demand more precise needle placement. We are targeting small, specific structures, often sitting right next to nerves and vessels. If you cannot see the tip, you do not know where you are. Out-of-plane approaches do not give reliable tip visualization. What looks like the tip on screen may be a shaft artifact. You may believe you are at the target, when in reality you are too deep or too superficial. There are limited exceptions. Very small joints, finger interphalangeal joints, The trichotillometacarpal joint may require an out-of-plane approach for anatomical reasons. But in almost all pain interventions, we use in-plane. The rule is this: if you cannot see the needle tip, you do not inject. Fifth, positioning for in-plane. Now I will show you a short video. This clip demonstrates how we adjust patient and operator positioning to maintain an in-plane approach across different anatomical targets. As you watch, focus on one principle. We do not adjust the needle to the position. We adjust the position to maintain the needle path.
We were sparks on quiet streets, two hearts finding where to meet. But life pulled us apart, left me talking to the dark. If I called you tonight, would it feel the same? Or have we both moved on to different names? Take me back to the start, before the quiet and the scars. When the world felt small and your hands felt warm. Take me back to the start, if only for a moment. I've been up since 3, scrolling back where we used to be. Half truths in this late night chat, both of us knowing what a line that. Funny how we talk like we're fine, but your name still lives in my rhyme. Take me back to the start, before the quiet and the scars. Take me back to the start, before the quiet and the scars. When the world felt small and your hands felt warm. Take me back to the start, if only for a moment.
What you just observed is not just a technique. It is a mindset. Design the needle pathway first. Then position the patient to support that path. The needle path is fixed. Everything else moves around it. Sixth, real-time interpretation, reading the spread. During injection, ultrasound is not only a guidance tool. It is an interpretation tool. First, always stay aware of vascular structures in your field. You cannot always avoid them completely, but when you can, you should. More importantly, watch the spread pattern. This is where real-time interpretation becomes critical. For joint or bursa injections, the fluid should not form a localized bulge. It should spread smoothly, almost seeming to disappear into the space. If you see a focal bulge, you are not in the correct compartment. For perineural or interfascial injections, the opposite applies. You should see a clear, defined expansion around the target structure. If you see no expansion at all, one of two things is happening. Either the injectate is entering a vessel, or your visualization is inadequate. The spread tells you where you are. Trust the spread. It does not lie. Seventh, needle entry and selection. Needle entry depends on 3 factors: the probe type, the surface geometry, and the depth of the target. For a linear probe on a flat surface, the elbow ECRB injection, or a shoulder subacromial injection, the entry point should be about half a centimeter from the probe edge. In these cases, the needle tip appears on the monitor close to the edge of the image, near the surface. For curved surfaces, a cervical nerve root block, or a plantar fascia injection, increase the distance to around 1 centimeter.
If only for a moment. I've been up since 3, scrolling back where we used to be. Half truths in this late night chat, both of us knowing what a line that. Funny how we talk like we're fine, but your name still lives in my rhyme. Take me back to the start, before the quiet and the scars.
Needle length should match the depth of your target. Superficial structures need short needles. Deeper targets need longer needles, and as depth increases, control matters more than stiffness. In my own practice, I use needles ranging from 1/2 inch to 2 inches. Most often, a 1.5 inch needle. Occasionally, an 8 cm spinal needle for deeper targets. In very superficial areas, as I said earlier, puncture first, then position the probe. This avoids probe cover contamination and improves trajectory accuracy. And always anticipate tissue characteristics before you begin. Plantar fascia injections, for example, involve high acoustic attenuation. Adjust your approach and your imaging parameters accordingly. Match the tool to the target. Always. 8th. Needle control, feel, not force. For beginners, one of the most common technical errors is applying force to the needle. If you use force, you lose control. The needle bends. The trajectory deviates. The patient feels unnecessary pain. Take a cervical periradicular injection as an example. Before you advance, find a position that lets the patient's neck fully relax. Then advance the needle without force. The correct sensation during needle advancement is a smooth, continuous glide. Minimal resistance. Steady progression. If you feel significant resistance, stop. Resistance means you are either in the wrong tissue plane, or your approach angle is wrong. Here is one important detail. Once the needle penetrates the overlying fascia, you cannot freely change your angle. The tension of the fascia and surrounding tendons will resist any deviation. Forcing a new direction will only bend the needle. So do not bend the needle along its path. Do not push through resistance. Reassess, reposition, and re-advance. Feel is information. Use it. 9th, the convex probe, understanding the geometry. The convex probe introduces a challenge that catches many operators off guard. The image on screen looks triangular. The beam appears to fan outward from the curved surface, spreading toward both lateral edges. This geometric difference is the most common source of error when transitioning from a linear probe to a convex probe. Here is the trap. When a beginner sees the curved surface of the probe, the natural assumption is that the beam radiates outward at the same angle as the surface curve, like an open fan, or like the eaves of a thatched roof spreading wide. Following that assumption, they place the needle near the lateral edge and angle it outward, expecting the beam to follow. It does not. I tested this myself. I placed a thick needle vertically at the lateral edge of a convex probe to see how far the imaging field actually extended. The results surprised me. The beam radiates far less than the curve of the probe surface suggests. Most of the lateral spread happens only at depth, like rainwater dripping nearly straight down from the eaves of a roof, not flying outward. In practical terms, this means you should treat the convex probe almost like a slightly raised linear probe. The center of the surface is only about 5 mm higher than the edges. The image it produces is not a wide fan, it behaves much closer to a rectangle. So when you design the needle trajectory, do not aim along the tangent of the probe's curved edge. That logic does not match the actual beam geometry. Instead, target the center of the probe. The center of the probe corresponds to the center of the image, and that is where your needle will be most reliably visualized. The best approach is this. Enter slightly away from the lateral edge, at sufficient depth, and advance the needle parallel to the flat plane of the probe. When the needle stays parallel to that plane, visualization is maximum. As the needle angle steepens, visualization fades. This is a fundamental physical principle. The needle reflects best when it is perpendicular to the ultrasound beam. As the angle approaches parallel to the beam, meaning steeply downward into the tissue, the echo is lost. There is one more issue. Convex probes are used for deeper targets. And at depth, a small change in probe tilt creates a large change in where the needle actually lands. The further the target, the bigger the error from a small angulation mistake. So when you use a convex probe, keep the probe held flat and stable. Eliminate unnecessary tilting. Minimize every source of angular error. On top of that, deeper tissue brings more acoustic attenuation. The needle becomes harder to visualize at depth. So the rule is this. Do not be fooled by the curved surface of the convex probe. Do not aim along the tangent of its edge. Treat the probe as a slightly raised linear surface. Enter near the center, parallel to the flat plane, and trust the beam, not the curve. 10th. Slow technique, speed hides mistakes. Finally, and this applies to every step we have discussed, everything must be done slowly. Slow needle advancement. Slow injection. Keen interpretation. Speed hides mistakes. When you move slowly, you can feel tissue resistance. You can watch the spread in real time. You can correct your trajectory before the error becomes a complication. When you move fast, you lose all of that feedback. Slow is not inefficient. Slow is controlled. And control is the entire point. Ultrasound-guided injection is not simply the act of inserting a needle. It is a three-part discipline. Setting up correctly. Executing with precision. Interpreting in real time. Every principle in this lecture exists to support one goal. Put the right substance, in the right place, at the right depth, every time. If you control what you see, you control what you do. And if you control what you do, you control the outcome. Thank you for joining me today and watching. It is my honor to be with you. As esteemed premium members, your support greatly motivates my journey of practical pain management on YouTube. I look forward to seeing you in the upcoming videos.